Thank you.
Okay, thank you so much.
Good afternoon. I invite Dr. Josh Matthew, who is a moderator of this session, to introduce and invite chairpersons for this session. Dr. George.
I am happy to be a part of this session, and I would like to introduce and invite the chair, Dr. Shivang Swaminarayan. Sir is an honorary physician to His Excellency Governor of Gujarat. And we also have Professor Dr. Shubhamoy Ghosh. He is working in the capacity of professor and head of the Department of Pathology and Microbiology and visiting physician at D&A Homeopathic Medical College and Hospital, Government of West Bengal. And he is also one of the members of the Scientific Advisory Committee of DAC, RRI, and CRU Siliguri. He is former member of the Drug Proving Committee at MCH under Central Council for Research in Homeopathy, Government of India. Welcome to both the honorable chairs.
Start with the session. We have our first speaker, Dr. Subranil Saha, to present the psychometric validation of modified Naranjo algorithm used in homeopathy for chronic disease. Over to you, Dr. Saha.
As already said, the title of the paper is Psychometric Validation of the Modified Naranjo Algorithm Used in Homeopathy for Chronic Cases. First of all, thanks to all to my chair, the coordinators, the moderator, and the respected audience for attending this session. And it was wrongly classified as an RCT. Obviously, it's not an RCT. It was a mixed method study. Anyway, LMHI, thanks to LMHI for providing me this wonderful opportunity. And as always, LMHI is always special to us. This study was carried out as a CCRH project 4 or 5 years back. And it was a long-term project. And finally, we tested a formal validation of the Naranjo algorithm in homeopathy. I'm going to elaborate a brief very briefly about this. Slide. Yeah. The paper was published in Journal of Complementary and Integrative Medicine, published by D. Grotter, and it was indexed in PubMed. And before going into the details, we should have a very brief knowledge about what is Naranjo and how does it evolve. And as all of you know, Naranjo criteria was actually developed by a renowned epidemiologist, Dr. C.A. Naranjo. And it was named as Naranjo criteria for assessing adverse drug reactions. So it was not meant for homeopathy actually. It was for assessing adverse drug reactions for modern medicines. So he developed this 10-point criteria for assessing adverse drug reactions. And then it was applied in the context of homeopathy by the renowned researcher, Dr. Lex Rutten. And he developed this 11-item criteria. And it was published in the journal Complementary Therapies in Medicine, and the Naranjo algorithm for homeopathy looks like this. It was initially an 11-item criteria. Then it evolved again in the meeting of the Homeopathic Pharmacopoeia of the United States, and it was a 10-item scoring system. It was named as Modified Naranjo Algorithm for Homeopathy. It was published in the journal Homeopathy in 2015. Then in 2020, a paper was there by Dr. Lamba. Modified Naranjo algorithm was renamed as Modified Naranjo Criteria for Homeopathy Causal Attribution Inventory and is termed as Monarch. So in this paper, Dr. Lamba checked the validity in a retrospective way. That means she checked the validity of the Monarch or Modified Naranjo, whatever we say, from already published case reports. But naturally, while testing for validation, we should always depend on prospectively collected data, not retrospective. So at this juncture, we launched the project and it came up as modified Naranjo algorithm prospective validation. Yes, this is the point. This was for the first time ever, a validation of a homeopathic tool was carried out by us, and it was published in 2021. So in brief, whatever I have told until now, this can be summarized like Naranjo algorithm was developed in 1981 by Dr. Naranjo. It was adopted, there was a proposal to adopt this in homeopathy. It came up in 2013 by Dr. Lex Ratten. Then it was further modified in 2015 by Dr. Ratten again. It was the retrospective validation was carried out in 2020 and 2021. And as well as the prospective validation was also carried out by us, and it was published in 2021. And right now we are further fine-tuned the version, and we are working on newer version is coming up. We are working on a newer tool, a new refined tool of Naranjo, which we are currently working on, but that I am not going to discuss in this presentation. So we are limiting our discussion only on the prospective validation of Naranjo criteria. So as I have already told, the first and foremost objective was to examine the properties, psychometric properties, the formal validation properties of modified Naranjo criteria. And the most importantly is to validate it from prospectively gathered data. That is the most important of all. And not only that, we'll be checking about its appropriateness using a consensus among experts about this tool. And finally, we'll be checking its construct validity again from another set of prospectively gathered data. I'm detailing it. So definitely, as the objectives are different, so we have to adopt a mixed method design. I have a pictorial presentation of this mixed method. I'm just discussing it. So at the first step, we tested its agreement, whether the Naranjo algorithm is suitable for homeopathy or not. We initially developed a panel of 25 experts, including many members from LMHI team itself. That means the team consists of both national and international experts who were trained homeopaths, and they have experience in academia as well as research of 5 to 10 years. This was the criteria for this expert panel. Nextly, we tested the formal validity by using exploratory factor analysis using a principal component analysis model. All this data was collected from the clinical verification program of CCRH. Then we tested the inter-rater agreement of case assessment using a different form of statistics called kappa. And then a test-retest reliability was assessed, followed by the final test of model fit, that is the confirmatory factor analysis model, again using another set of prospectively collected 150 data. All this analysis was carried out in SPSS and AMOS. So this is the mixed method approach, what I was talking about. So first of all, we did a face and content validation of the Naranjo algorithm by a panel of 25 experts. Then it was field tested. Then the 285 Naranjo responses and Glasgow responses were collected from patients. Construct validity was tested using principal component analysis. Then this analysis was done on 285 responses. Finally, again, another 150 data was collected on which confirmatory factor analysis was run. So these are two different sets of data. Side by side, we did two tests. One is inter-rater agreement and another is test-retest reliability. And finally, we came up with the validation and reliability statistics of the Naranjo algorithm, which is to some extent problematic, but can be improved. It was the descriptive statistics where we obtained the patient response. All the patients were suffering from some kind of chronic diseases and were enrolled in the clinical verification program of CCRH. during the tenure of 2015 to 2020. And the patient responses were gathered in the year of 2017. All these are prospectively gathered cases. And as you can see, two readings. One is Glasgow Homeopathic Hospital Outcome Scale, which is currently also named as ORIDL, outcome related to daily living. And these are the modified Naranjo scoring, the score which was developed by Lex Ratten. These are corroborated. You can see, just to give an example, when Glasgow scores are high, for example, +4, Naranjo scores are also high. That means it comes as +8 or +9. There are some outliers. Definitely, there will be some outliers, but majority of the data fitted this. And regarding the expert responses, the 25 panel expert, we asked the experts to reveal their agreement on the Naranjo items, whether they agree it or not on a 5-point agreement scale. And what responses we got from the experts, they almost agree, all of them agreed on the items. The mean scores was 4 or higher, and the outliers were very less. Standard deviation was less than 1. So what we can say is Glasgow scores corroborated well enough with the Naranjo scores. Then we run a scree plot to check the unidimensionality of the items. Here we can see in this graph, out of the 10 items, see 1, 2, 3, and 4 items have high eigenvalues. That means the 10 items are constructed within this 4-component model. So out of the 10 criteria proposed in the modified Naranjo algorithm, the whole instrument is composed within these 4 domains or 4 subscales or 4 component, whatever you can say. And it is also evident in the this rotated component matrix. It is a orthogonal rotation was carried out using Varimax. See, under the first component, item number 4, 5, 6, and 9 comes. Under domain 2 comes item 1 and 2. Under component 3 comes item number 8 and 10. And under domain 4 comes item number 3 and 7. So we assumed, and it is quite evident that although Naranjo algorithm has 10 items in it, the items are clustered into 4 components. Okay. And then we tested the internal consistency using Cronbach's alpha, and it was almost borderline, not really very promising, still borderline, and it was in an acceptable range. Also the intra-class correlation coefficient also. Now, another important part, we tested the inter-rater agreement, and but there were substantial variations in rating between 2 raters. Item 1, 2, and 8 out of 10. Item 1, 2, and 8 scored quite fair. 3 items were moderate, but rest of the items are poor. We called upon 50 patients whose clinical states were not changed, and we confirmed this over phone. And after a 15 days treatment period, we called those patients again, and again 2 experts filled this Naranjo score again. And in this, we see there is no significant difference. P values are almost non-significant. That signifies that it has promising test-retest reliability. And finally, this CFA model was developed on another set of 150 data, and almost all the model fit indices like comparative fit indices, normed fit index, Tucker-Lewis index, Holter index, all these are almost in acceptable domain. So see, under the domain 1 comes item 4, 5, 6, and 9. Under domain 2 comes item 1 and 2. Under domain 3 comes item 8 and 10. Under domain 4 comes item 3 and 7. So ultimately, it shows overall this model fit statistics shows revealed promising statistics and can be accepted. What we can say is this model is more or less acceptable, but what is also evident that it needs some sort of improvement. See, some eigenvalues are less, 0.27. This is 0.22. So these values are quite less. So this can be improved. So we are working on this very project again, how to improve this Naranjo scoring. As I have already said, that major strength lies that the two major analyses, that is exploratory and confirmatory. These were run on two different sets of prospectively collected data. This is the major strength of the study. And before running this kind of analysis, we tested its sample size, its KMO statistics. There is another thing I'm not going to detail. This signifies that the sample size achieved was quite promising. And weakness was, as I highlighted, that it was borderline Cronbach alpha. Some inter-rater agreements were poor. Few items needed improvement, as I already told. And Naranjo, different weights are assigned to different items. This is some sort of difficult to understand. So future research is whether it can address the placebo effect. As in my earlier session, Dr. Munmun Kole, we have tried this Naranjo to how can it differentiate between medicine and placebo in randomized control trial? Yes, and Naranjo can differentiate medicinal effect from placebo effect in randomized control design, as Dr. Munmun Kole in the previous session has already discussed this thing. Few caveats were identified, and we are trying to improve this, as I already told. So final conclusion is that Monarch or modified Naranjo is consisting of these four domains: holistic remedy reaction, specific remedy reaction, confirmation of remedy causality, and temporary adverse effect expected in homeopathic treatment. So what is warranted is further refinement and further improvement of the rule. Thank you. This I'm from DN Homeopathic Medical College and Hospital. It is a government college in West Bengal. Thank you. Thank you all.
Thank you, Dr. Subranil Saha, for your excellent presentation. I think I will invite the chairs for their valuable responses.
First, I'd like to congratulate Dr. Subranil Saha for your nice deliberation, and kudos to the whole team, because this sort of study is very important nowadays. So my question is, what is the very important question actually from the desk of the audience? What is the utility or practical feasibility in point of clinical practice and trial, as well as the pharmacovigilance? This is a very new area in homeopathy. So do you kindly show some light for the audience at this?
Very fantastic question. And what is actually the practical adaptability? Whatever I have discussed is extreme kind of methodological or statistical things. But the question in a nutshell is, what is the adaptability of this kind of research? Yes. See, in a clinical practice, whenever we administer any kind of medicine, there are three states coming up. One is either the patient will improve, either the patient will deteriorate, or the patient will remain standstill. But whether this outcome can causally be related to your medicine or something else, this probability calculation is done by Naranjo. Naranjo is made for that. And whatever we are doing, we are trying to just fine-tuning the instrument so that this precision can be more perfectionized in future. That was the purpose for which Naranjo was developed, and we are gradually fine-tuning this currently in DN college. This was the purpose.
And what's about pharmacovigilance? Because this is a new area.
Obviously, it should be used in pharmacovigilance, what is now going on in our colleges. Yes.
Thank you.
Any comments from Dr. Shivang?
First of all, congratulations, Dr. Saha. And I look at it from a different perspective. I hope I'm audible.
Yes, sir. Yes.
So far, we have been finding various criticism to the scientificity of the homeopathic treatment from all over the world, because we didn't have the tools which modern medicine or the modern scientist would be able to understand, and they would like to, they may correlate our experiences, our observations, our studies, and our outcome. So this is a very unique step and very important step, which started probably in 2013, and we are talking in 2021, and yet we see that we have not yet developed it to the fullest extent, because it's an evolutionary process, and I'm sure that maybe within a short period of time of maybe a couple of years or maybe 5 years, we should be able to have a model which is universally acceptable not only to homeopaths but also to the medical fraternity at large, universally. And that would be a major step in putting, or a major step to prove homeopathy and its scientificity, which is a big question mark today in the scientific world. So I once again congratulate, because I know Lex and I know that the kind of the sessions what he has taken at CCRH in past, and wherein I was also a member of the CCRH committee. And to summarize, I see a great scope and for the newer paradigm in scientific study and the modeling and the analysis of our studies in time to come. Thank you.
Thank you, sir.
Thank you. Our next speaker is Dr. Akash Deep Das. I invite him to present efficacy of individualized homeopathic medicine in irritable bowel syndrome. Over to you, Dr. Das.
Respected chairpersons, moderators, and learned delegates, a very good afternoon to all of you. Myself, Dr. Akashdeep Das. I am postgraduate scholar of Mahesh Bhattacharya Homeopathic Medical College in the Department of Case Taking and Repertory, West Bengal, India. Today's topic of my presentation is efficacy of individualized homeopathic medicines in irritable bowel syndrome, a double-blind randomized placebo-controlled trial. This study was undertaken as a part of the postgraduate dissertation done under the guidance of Professor Dr. Shubhamay Ghosh sir, my PG guide. And just some basics about the IBS. The operational definition of the irritable bowel syndrome, according to Rome 4 diagnostic criteria, is a recurrent abdominal pain on an average at least 1 day per week for at least 3 months, associated with 2 or more of the following complaints, like pain related to defecation, associated with change in frequency of stool, associated with change in form of stool. And this criteria should be fulfilled for at least 3 months with the symptoms onset at least 6 months prior to the diagnosis. The ICD-10 code for IBS is CMK58, as we all know. So just a little bit about the introduction of why this study was undertaken, and just slight bit of a justification, because the condition of IBS is one of the commonest conditions that is being treated by homeopathy, and yet there are very few trials which have explored the efficacy of individualized homeopathic medicines in irritable bowel syndrome. So why RCT design was used? Because it is a functional disorder with a very low chance of turning fatal, and that too when we miss the diagnosis of the IBS, that happens. And also the RCT is a very gold standard for measuring the efficacy of any therapy. So going to the aims and objectives of the study, aim was to evaluate whether the individualized homeopathic medicines is better than placebo in treatment of patients suffering from irritable bowel syndrome. Objectives to determine the group differences in IBS quality of life scores over 3 months, to determine the group differences in IBS symptom severity score over 3 months, to determine the group differences in EQ5D5L scores over the 3 months, and also to ascertain and shortlist the frequently indicated homeopathic medicines and their indications in the treatment of irritable bowel syndrome. Methodology. Coming to the study design, that is, it is a double-blind randomized placebo-controlled trial with 2-arm parallel clinical trial, and study setting was the OPD of Mahesh Bhattacharya Homeopathic Medical College and Hospital. Selection of the sample was done for the patients suffering from IBS and also fulfilling the prerequisite eligibility criteria. And also the patients selected from the OPD of Mahesh Bhattacharya Homeopathic Medical College only. And sample size was 60 patients, and study duration was of 12 months, as it was a PG synopsis. And ethical issues, the institutional ethical committee cleared this had given the certificate of clearance, and also patients were given written informed consent were taken from the patients. Trial was prospectively registered with CTRI on 14/10/2019. Coming to the inclusion and exclusion criteria, patients who are suffering from IBS, as per inclusion criteria was those patients who are suffering from irritable bowel syndrome, as per Rome 4 diagnostic criteria were included in the study. Patients of either sex, age 18 to 65 years, the literate patients who are ability to read Bengali and or English or both. Patients willing to participate in the study and giving written informed consent. Exclusion criteria: patients who are too unwell to take part in the study, diagnosed cases of unstable psychiatric or any other systemic disease, any major gastrointestinal surgery in the last 6 months, currently receiving standard therapy for irritable bowel syndrome or any other homeopathic treatment for any chronic condition, pregnant and lactating women, self-reported immunocompromised conditions, substance abuse or dependence. Next, intervention. There were two arms: experimental arm, individualized homeopathic medicines in centesimal potency, and comparator arm is identical looking placebo. Concomitant care was given to both the arms. That were dietary management, high fiber diet, and stress reduction. Next, duration of therapy for each patient was 3 months, and outcome assessment was primary outcome IBS quality of life questionnaire score, measuring the health related quality of life, and secondary outcome was IBS symptom severity score and EQ 5D 5L questionnaire scores. Follow up every 3 months, every month up to 3 months. Statistical methods, intention to treat analysis were used. Missing values were replaced by regression means. Group differences using two-way repeated measures ANOVA and unpaired t-test were used. Trial reporting as per consort guidelines and red hot guidelines. Next, this is the study flow diagram as per consort diagram. The total 93 patients were screened, among whom about 33 patients were excluded, of whom 19 had denied consent, 7 were severely ill, 5 had uncontrolled systemic disease, and 2 were already undergoing homeopathic treatment. 60 patients met the eligibility criteria and were enrolled and randomized. 30 patients were given placebo and 30 patients received individualized homeopathic medicines. In the placebo arm, 3 patients were lost to follow-up, and in the individualized homeopathic medicine arm, 2 patients were lost to follow-up. At last, 27 patients on the placebo arm completed the trial, and 28 patients in the individualized medicines completed the trial. At the end, endpoint analysis was intention to treat analysis was used. Coming to the observation and results, groups were comparable at baseline, and the attrition rate was 8.33%. The group differences in IBS quality of life scores, IBS symptom severity scores, EQ 5D 5L scores, VAS scores, favored individualized homeopathic medicines against placebo. A total of 39 medicines were used in the study, amongst which pulsatilla nigricans, Puja occidentalis, Natrum muriaticum, and sulfur were the most prescribed medicines. Barring minor injuries and mild fever, which were also managed by homeopathic medicines, no harms or serious adverse events were reported in the either groups. This is the statistical analysis of the primary outcome. We can see that the IBS quality of life total scores had favored individualized homeopathic medicines over placebo at all points of time. We can see the graph on the right side. Next is the inferential statistical analysis for the secondary outcome of IBS symptom severity scores. Here also, individualized IBS symptom severity scores favored individualized homeopathic medicines against placebo at all the times. This is the graph for the EQ 5D 5L questionnaire scores. On the left side, we can see the changes in the mean EQ 5D 5L questionnaire scores over the different points of time in the two groups. And on the right side, we can see the changes in the mean EQ 5D 5L VAS scores over different points of time in the two groups. So coming to the discussion, the strength of the study, that is a gold standard design is to evaluate the efficacy was used, and also intention to treat analysis and was used as a statistical in the endpoint analysis, and validated outcome measures were used. The limitation of the study is that a very small sample size was used, and that too a very short study duration was done. Study was completed in a very short duration of time. Lack of objective outcome measures were there. So it was a very big amount of limitation. Next, in the future research, we aim to do similar studies with larger sample size and use 50 millisiemal potencies, and also do multicentric studies, and a longer duration of study has to be undertaken. Conclusion: in this double-blind randomized control trial, 60 patients suffering from irritable bowel syndrome, improvement was significant in the individualized homeopathic group over than the placebo group. However, owing to the small sample size, a confirmatory conclusion cannot be drawn. Adequately powered trials with independent replications are warranted. Last of all, I thank all my co-researchers, and also I thank the LMHI for giving me this wonderful stage to present this work. And thanks from the MBH MCH RCT team. Thank you.
I would request Dr. Shivang Swaminarayan to give his comments.
First of all, I'm happy that this is one of the few conferences where such a large number of RCTs, various RCTs are being presented. And that shows that how important RCTs are in various diseases to prove or further kind of be strategize the treatment protocol and the scientificity parameters. And as this was a first one of its kind, because of the paucity of the time frame that the scholar has during his PG studies, but it's a good initiative, and I wish that in future larger long-term and multicentric trials of such study are designed, and it is also in collaboration with the regional research centers of the country, because that would give more insight and more meticulousness about the study. And because we see that India is a large country with a lot of diversity in its culture, diet, the disease burden. We can say that the Asian countries has got IBS burden of up to 20%, wherein India stands somewhere around 15% disease burden due to IBS. And I know the figure that the Northern India contributes to something less than 5%, but I'm not sure of the Western India, Eastern India, the Central India, and the Southern India. So the geography also plays an important role, and wherein multicentric long-term and larger trial would give us a more insight. Once again, congratulations to Dr. Das and his guide, Dr. Shubhamoy.
Thank you, sir.
The next speaker, Dr. Nivedita, to give a presentation on the effectiveness of individualized homeopathic treatment in cases of insomnia. Dr. Nivedita?
Yes, am I audible?
Yes, you are.
Okay, and kindly see if my PPT is visible or not.
It is visible. You may proceed.
Okay. Thank you so much, everyone. First of all, good afternoon to everyone, the respected chairpersons, moderators, session coordinators, and panelists. The topic for today I would like to present is on the efficacy of individualized homeopathic treatment on insomnia, a double-blind randomized placebo-controlled clinical trial. Myself, Dr. Nivedita Kundu, I would like to present this research paper. So basically, I would like to start with a quote given by William Dement, a sleep scientist, co-discoverer of REM sleep. As far as I know, the only reason we need to sleep that is really solid is because we get sleepy. Though there are many theories that have been put forward to try to answer the question why we really need sleep, but this remains unanswered. But we definitely know the beneficial effects of a good sleep on the overall health and the bad effects of not getting a good sleep that are better recognized by the scientific community in the past few decades. Is my screen moving?
Yes.
Okay. So basically, we know the insomnia, also known as sleeplessness, is defined as difficulty in initiating sleep or maintaining sleep. Sleep difficulty at least 3 nights a week, or sleep difficulty that causes impairment of data functioning. Insomnia is the most common sleep-related complaint associated with impaired daytime functioning, reduced quality of life, increased morbidity, and substantial societal cost. Other common sleep-related disorders are narcolepsy, sleep apnea, restless leg syndrome, and hypersomnia. We know that drug-dependent insomnia are always not always fully effective and also have many adverse effects. Many studies on homeopathic treatment on insomnia are either poorly reported, then underpowered, or they do not include an ITT analysis or do not follow an individualistic approach. So basically, our aim was to evaluate the efficacy of individualized homeopathic treatment over placebo, if any in the treatment of insomnia, by detecting the group differences. We also intended to evaluate and shortlist the most frequently indicated homeopathic medicines. The study design was basically double-blind, randomized, prospective, placebo-controlled, 2 parallel arms clinical trial which was set up at the National Institute of Homeopathy. The blinding was pharmacy-controlled. That means the randomization chart was with the pharmacist who was responsible for dispensing the medicine or placebo according to the randomization number. The unblinding was done only after the study was completed and database was frozen. The sample size of the study was 60. And the outcome measures, the primary outcome measure was sleep diary. Sleep diary is basically a daily written record of an individual sleep week pattern containing such information such as time of retiring and arising, time in bed, estimated total sleep, number and duration of sleep interruptions, and quality of sleep. The advantage of the sleep diary is basically its prospective nature, which is less subject to biasness. It also yields a series of quantitative values that can more precisely describe an individual's sleep pattern. And it can also be useful in delivering behavioral treatments or measuring the treatment-related changes. The data from the sleep diary was basically imported into a master sleep diary calculator, which was developed by Center of Development of Psychology, USA, and which has basically 6 items. The items are: number 1, latency to fall asleep; number 2, minutes awake in the middle of night; third, minutes awake too early; hours spent in bed; total sleep time; and sleep efficiency. The secondary outcome measure is Insomnia Severity Index. It is also a 7-item measurement tool that is a quantitative index of sleep impairment, and it provides the information of patient's perception on the severity of insomnia. Also, the level of distress and impairment of data functioning can be assessed. The timelines are collected, the data have been collected basically at the baseline and after 3 months of the treatment, though follow-up was done every month. The study flow chart, it can be seen that the screening of 174 participants was done as per the eligibility criteria, and 114 were excluded due to various reasons like illiterate, uncontrolled diabetes, hypertension, pregnancy, substance abuse, substance dependence, psychiatric illness, etc. 60 participants were randomized and enrolled in the Verum or control group. 30 received the individualized homeopathic treatment, whereas 30 received the placebo. In case of statistical analysis, the intention to treat approach was followed. It means that every included patient entered the final analysis. The baseline missing values were replaced with regression means, and by the last observation carried forward method. Now coming directly to the result section, in the first graph we can see that we had conducted a pair-wise pair test comparing baseline and after 3 months under the Verum group. 5 out of 6 items of sleep diary, excepting the item 3, there was significant improvement. And in case of the insomnia severity index, we can understand that the severity should decline. So basically, at the baseline, both the Verum and control, they were comparable. So after 3 months, we can see that there was significant improvement in the Verum group as well as control group. But Verum group had significant there was significant decline and significant improvement in after 3 months. Overall, we can say that individualized homeopathy seemed to produce a significant effect better than placebo. So we understood these two graphs. That means as compared to placebo, the Verum was effective. These were the medicines indicated at the baseline. Nitramur was most frequently used. And if we come to the discussion section, the basic strength was because this RCT was methodologically sound, ITT analysis was conducted, red hot guidelines and concert guidelines were followed for reporting trials, and basically the data is freely available on Mendeley data repository. Talking about the limitations, this study was underpowered. The duration of the study was also very small, that is only 3 months. It was a single center study. Multi-center study could have been produced far better results. Then we could assess only the outcome assessment was only based upon the subjective assessment. And sleep diary and insomnia severity index, they were both the subjective assessment, but for objective, we could have taken the polysomnograph and actigraph as well as EEG scores. This could not be assessed. Also, we could not assess on the role of mother tincture, biochemics, or complex homeopathic formulations also. So further researches are required. Though with this small scale study, we can conclude that individualized homeopathy seemed to produce significantly better effect than the placebo. This research was published in the Complementary Therapies in Medicine. That's all. Thank you, everyone, and have a good day. Thank you for giving me this opportunity to speak.
Thank you, Dr. Kundu. Actually, we are running short of time, so I
Yes.
say that, and I would request the chairs to give their comments in alternate presentations. So I would request Dr. Ghosh to give his comments now. Please.
Yes. Nivedita, thanks for your commendable work. My question is, what is the utility of insomnia work in the scenario of COVID-19? Number one. And do you know what is about, is there any idea about the translational research, which is very important nowadays? So is there any future plan of research in translational research? Do you know what is translational research?
Sir,
So
sorry.
most of the research,
Yes.
most of the researchers, basic researcher who is correlated with neuroscience, specifically JNU researcher, whose laboratory is sleep and dream research. So you may conjointly work together.
Yes, sir, definitely I'll try.
So what is your future plan of this study?
So research is the need of the hour, what I know. And as far as homeopathy is
In the perspective of insomnia.
Sir, in insomnia, we know modern medications are being taken in insomnia, are being taken by the insomniac patients. But due to this less effectiveness and adverse effects, many tried the alternative therapies like homeopathy. So, but we should be sure whether our medicine really work or it is the psychotherapy or other counseling factors which give in.
Whether the
So,
questionnaires are validated, what
sorry, sir.
the questionnaires used here is a
Yes, sir.
validated one.
Yes, sir. They were validated. We had
Okay.
translated in Bengali questionnaire, but that needs to be validated too.
Okay. Thank
Yes.
you.
Thank you, sir.
Thank you. I invite our next speaker, Dr. Sangeeta Saha, to give a presentation on the efficacy of homeopathic medicine in cutaneous warts, a double-blind, randomized, placebo-controlled pilot trial.
So, very good afternoon to the learned delegates and respected dignitaries, moderators, session coordinators. So, myself, Dr. Sangeeta Saha, Professor, Department of Organ and of Medicine, will present a study carried out at DND Homeopathic Medical College and Hospital. So, under the short-term studentship in homeopathy in the year 2019, under the guidance of Professor Dr. Samit Dey. So the topic title is a randomized double-blind placebo-controlled pilot trial of individualized homeopathic medicine for cutaneous warts. There's some issue with the... Okay. So this study was published in Homeopathy 2021 in March 2021. This was also indexed in PubMed journal. So as we all know that the skin warts are the benign tumors caused by infection of keratinocyte by human papilloma virus, which is visible as a well-defined hyperkeratotic protrusion. So they adopt a variety of pattern depending on the anatomical location, morphology, immunological states, treatment history, and etc. The global burden of warts is with an average of disability weight of 0.029, and the prevalence is 10 to 20%. And India being a mostly tropical country favoring viral infection, including warts, so the prevalence is much more in India. The great effect of this, as we all know, being this lesion, which is affecting the skin. So it's having a cosmetic value, and thus it grossly affect the quality of the life of the patient, resulting because of the embarrassment, fear of negative appraisal, frustrations, and the recurrence and all other things. So if we see with this, there are some there are good number of research case reports, there are some even RCTs, but the sound trials of individualistic homeopathic medicine in warts is still deficient. So if we go with the homeopathic view, we will see that though the warts is manifested as a local disease on the external part of the body, but we know that the local disease is not chiefly local. It has got some internal derangement. So we can think about that homeopathy can act in a much more holistic way, or in cases of the warts. So this study was aimed to assess the difference between individualistic homeopathic medicine and placebo in treatment of cutaneous warts, as well as it was aimed to explore the feasibility of a future large-scale trial. Moreover, it was to evaluate the efficacy of individualistic homeopathic medicine against placebo in treatment of warts. Again, another objective was to detect the difference in size and number of warts between the two groups. The number and the size which was measured with this vernier caliper, digital vernier caliper, to detect differences in dermatology life quality index score between the two groups. And last but not the least, to shortlist the most frequently indicated homeopathic medicine for warts in their treatment. So if we go with the methods, as already discussed in the title, it was a double-blind, randomized, placebo-controlled to parallel arm trial. This study was carried out at DND Homeopathic Medical College, as I told you, that as a STSH project. The duration of the study was of 6 months. It was started in October 2019, and it was completed in March 2020, and the last patient which was enrolled in January 2020. So the sample size, it was 60 with a 1:1 ratio, so thus 30 in each arm. The randomization, for regarding the randomization, start rate was used, the permuted block randomization method was used, and 6 blocks consisting, each block consisting of 10 patients. It was a double-blind study. The masking of the patient, investigator, outcome assessors, pharmacists, and data entry operators all were blinded, and it was only decoded once the study was over. The allocation concealment was there. It was an identically coded vial. If you see, there are 2 vials. One is individualistic homeopathic medicine, and another one is the placebo. And they were marked as a code 1 and code 2. So if we go with the inclusion and exclusion criteria, so the person suffering from wards aged between 18 to 65 years of both the sex, literate patient, the persons with the cutaneous wards who were not taking any medicines in the last 1 month, they were included. For the study, the anogenital and the genital wards were excluded, as because we have already discussed that it was dealing with the dermatology quality life index. So we have excluded those patients who are unstable psychiatric, having unstable psychiatric illness, and those who are having any defect in the or disease in the quality of life. So we have also excluded immunocompromised patient, pregnant and puerperal women, lactating mothers, persons with substance abuse, and any patient who is undergoing any treatment or specifically homeopathic treatment within the last 6 months. So as already discussed, it was an intervention. The verum is to individualized homeopathic medicine in centesimal scale. It was a identical looking placebo, and the special thing that was given advice that the patient were advised to go with the hygienic measures, that is to wash their hand after touching the wards, avoid brushing, combing or shaving or picking the particular wart area. For each patient, the treatment of therapy was 3 months. Now, if we go with the outcome measures, we will see it was the primary number and size of wards, and secondary it was dermatology quality life index questionnaire and its subscale. The timelines, each patients, they were followed up and their data were collected at the baseline every month up to 3 months. The feasibility issues which was taken that the recruitment rate will be more than 50% and the retention rate will be more than 80%. Intention to treat analysis approach and the intra-group changes were measured by Friedman test and the inter-group differences by Mann-Whitney test. So regarding the ethical issues, this trial was placed before the institutional ethical committee prior to the enrollment, and the approval was received from the committee. Then it was registered in the CTRI, and here no new drug, no new protocol that was tried. All medicines were procured from the GMP certified company. And before enrollment, each patient were provided with the informed consent sheet, and which consists of the patient information sheet and written informed consent, and voluntary consents were obtained. So if we go with the consort study flow diagram, we can see that 89 patients were screened, out of which 29 were excluded because of the various regions. And you will see that the 60 patients, they could be enrolled as per the inclusion and exclusion criteria, as because we have already discussed that the allocation ratio was 1:1. So in one arm, we have received individualistic homeopathic medicine, that is N equal to 30. And on the placebo group, we have received or included 30 patients. Among the 30 patients in the individualistic homeopathic group, 3 patients, they left the study because of various reasons. And on the placebo group, 4 patients, they lost to follow-up because of the change of residence, and other one was not satisfied with the treatment, and they were followed up for 3 months. And then the endpoint analysis was done at the 3rd month. So if we go with the result, we can see that the recruitment rate was 67.4% and the retention rate was 88%. And during the study procedure, no obstacle was faced in relation to randomization, blinding, outcome assessment, and follow-up. So in this study, we have not received any homeopathic aggravation or serious adverse event. Even no such harm was noted in the patient. So if we go with the box plot showing the medians and interquartile ranges in the number of wards over 3 months, if we discuss the outcome, we will see that the number and size of wards, they reduced in the intra-group changes in the number of wards were noted after 3 months, which was significantly greater in the individualistic homeopathic group than in the placebo. However, in the intergroup, differences were statistically non-significant, owing with a very small effect size. If we go with the DLQI, we will see that except for the domain of leisure and personal relation, intragroup changes with time showed significant improvement in each domain and in total DLQI in the verum and the placebo group. The intergroup differences in all the domains was, however, not statistically significant. The most frequently indicated medicine in both the groups, that was the Thuja occidentalis, which was near about 28.3%, followed by natramur, that is 10%, then sulfur, dulcamara, nitric acid, anti-crude, causticum, muxol, calcarea carb, they were indicated as per the totality of the symptom of each case. So if we
Ma'am, just to inform you, your time is up. Huh?
Okay, ma'am. So just 2 minutes. If we go with the strength of the study, we will see that this was a gold standard because it was a double-blind randomized controlled trial. It was the intention to treat analysis was used. It was a subjective as well as in the objective. The DLQI being the subjective and the objective is the size and number. So we have followed up the consort and the red hot guideline, and the weakness is a small sample size and the short duration of follow-up. So the future researches are, we can think of longer duration of follow-up, histological examination, and immunohistochemistry or PCR for HPV DNA or human papilloma virus DNA. So the conclusion is, if we go with though the result of the study was non-significant, but it paves a way for a future adequately powered definitive trial that could enable detection of a clinically meaningful difference. So thank you. Thanks a lot for giving me this opportunity to present my the study carried by the DND team. Thank you. Hello.
I'll request Dr. Ghosh to give his comments.
Dr. Shangita, thanks for your commendable job in connection with RCT WARDS research. So my question is, what is the novelty of your research, which is very essential to know for the audience? What is the new of your research?
Yes, sir.
What is the novelty of your research?
Yes, sir. In this study, we have measured this the number. We have seen there are a lot number of case reports. There are some case series, observational study. There are some even RCTs. But here we have taken the subjective and objective phenomena. That is, we have measured the number of the wards, the changes in the number of wards. We have measured the number or the size of the wards measured with the electrical vernier caliper. And as because we have already discussed this thing, that this ward that they grossly affect the quality of life of the patient. So we have tried to corroborate the changes in the number size along with the this quality of life of the patient. And moreover, one very important thing is that we have tried to keep the concept, the pure concept of homeopathy, that is the individualistic approach. So there was no fixed medicine, there was no external application. Whatever was indicated in the patient, they were given according to code 1 or code 2. And as because we all know the gold standard is RCT, so this is the novelty, sir. So we have
Thank
tried
you.
our level best, but it was, as already discussed, that the time span was very short. So the result definitely paves the way for future definitive trial. So we will definitely try to do so.
Okay. Thank you.
Thank you, Dr. Saha.
Thank you.
I invite
for
Dr. Shruti
patience.
Rai to give a presentation on effectiveness of individualized homeopathic medicine in cases of acne vulgaris. Dr. Shruti?
Yes, ma'am.
Over to you. You can start your presentation.
Good afternoon, everyone. Myself, Dr. Shruti Rai, former PGT from National Institute of Homeopathy, Salt Lake, Kolkata. And my topic is efficacy of individualized homeopathic medicine in treatment of acne vulgaris, a double-blind, randomized, placebo-controlled trial, which was conducted at National Institute of Homeopathy, Salt Lake, Kolkata. Acne vulgaris is a chronic inflammatory disease of pilosebaceous unit and is estimated to affect 9.4% of the global population, making it the 8th most prevalent disease worldwide. There were previous studies on acne vulgaris, but there were poor reportings and lack of intention to treat analysis, and they were underpowered. Efficacy was done in individualized homeopathic medicine versus a placebo. Study design was double-blind, randomized, placebo-controlled, two parallel arms study in the dermatology and organ of medicine department of National Institute of Homeopathy. Randomization was done by permuted blocks by individual independent third party, and were randomized to either Verum or controlled group, which were equal in number. This was a consort flow diagram. 179 patients were screened as per eligibility criteria, and patients were excluded. 28 patients were excluded because they were illiterate, and few patients were denied consent, so they were excluded. 7 were suffering from severe acne, and few were going chronic undergoing homeopathic treatment for other chronic disease, so they were excluded. 126 patients met the eligibility criteria, and they were enrolled and randomized. 63 of them received individualized homeopathic medicine, and 63 of them received placebo, identically looking placebo. They were followed up at first, second, and third months, and seven were lost to follow up in each groups. Intention to treat analysis was adopted in the both Verum and placebo groups. Double blinding was done. The patient, the investigator, a pharmacist were blind about the randomization, and allocation concealment was done by identically coded containers with either medicated globules or placebos. Outcome measures were global acne grading system score, which was done by global score was evaluated by adding the local scores, and local score was evaluated by dividing the face and chest and back, upper back into 6 equal parts, as you can see here, and each were assigned a factor, and it was multiplied by the type of lesion it was having. For example, if it was having comedones, it was given 1 number. If it was having papules, 2 number was given, pustules 3 numbers, and cysts and nodules were given 4 numbers, and it was multiplied, and then local scores were added up. This secondary outcome measure was cardiac acne disability index, and there were five questions, and 0 to 3 marks were given to each questions. Dermatology life quality index was there as a secondary outcome measure, and there were 10 questions, and each question was to evaluate the patient's assessment of patient's assessment of how his skin condition is affecting his quality of life. This assessment was done. These assessments were done at the baseline at 3 months, and global acne grading system was done by the dermatologist, and cardiac acne disability index and dermatology life quality index was done by patients themselves. We will go to the results. If we see GAGS, the Global Acne Grading System score, the global acne grading system were comparable at baseline, and there were no significant group difference in distribution of GAGS score at baseline between groups. Intra-group changes after 12 weeks revealed significant improvement in both the groups. Group differences after 12 weeks, though favored individualized homeopathic medicine against placebo, still it was non-significant statistically. If we talk about cardiac acne disability index, it was comparable at baseline, and there was no significant group difference, and intra-group changes after 12 weeks of intervention revealed significant improvement in both the groups. Group difference after 12 weeks revealed similar improvement in both without any significant difference between the two. If we talk about dermatology life quality index, there was no significant group difference in the DLQI scores at baseline, except for DLQI symptoms and feelings, total scores. Intra-group changes after 12 weeks of intervention revealed non-significant improvement in both the groups. Group differences after 12 weeks revealed similar improvement in both the groups without any significant difference between the two. Conclusion: the effect of individualized homeopathic medicine in treatment of acne vulgaris were promising, but not clearly differentiable from placebo. Discussion: strength of the study was it was methodologically sound, intention to treat analysis, large sample size, and use of standardized and already validated outcome measures. The limitations of this study was short follow-up schedule, that was 3 months, and small duration of this study, that was from the October 2018 to May 2020. The publication status is accepted, paper in press. Thank you so much. And I would like to thank LMHI for giving me opportunity to present my work.
I would request Dr. Shivang Swaminarayan to give his comments. Sir.
Thank you, Dr. Matthews, and compliments to Dr. Shruti. But as you have found yourself that the study results are nothing significant than the placebo group, I think you can plan to have a more robust study in future. Yes, with your guide.
Sir.
Yeah.
Yes, sir.
Thank you, sir. Now I request Dr. Chitra to come up with a presentation on menopausal syndrome. Dr. Chitra?
First, I want to start with what is menopause. Menopause is the permanent cessation of menstruation. where the pathological causes of this state cannot be diagnosed. It is a retrospective diagnosis. It takes nearly 12 months to confirm it, 12 months of amenorrhea to confirm the menopausal syndrome. Now, according to ICD-10, the symptoms are, main symptoms are hot flushes, sleeplessness, headache, and lack of concentration. If you see globally, every year, 25 million women experiencing the menopause. In India, 60 million women are above 55 years. The majority would spend 1/3 of their life in the postmenopausal stage. So now what we will do, what kind of treatment we can give? If you see in conventional treatment, hormonal replacement therapy is the standard treatment, but there is a risk for breast cancer and stroke and heart diseases. So there is a risk. Next, if you see in complement and alternative medicine, there are some products like soy products and phytoestrogens. They are effective. In homeopathy, we are treating menopausal syndrome more than 1.5 years centuries, but still our research literatures are inconclusive. So if you see here, I had put some studies. There are 3 observational studies revealed the promising effect, and then a pilot RCT showed clinically relevant improvements. Then RCT on capsicum revealed a positive effect. Then a multicentric study, sepia with placebo, showed inconclusive result. So you can see now there is a lack of conclusive evidences in support of our individualized homeopathic medicine, the treatment of menopausal syndrome. So this is the reason we took this topic as a thesis. Next, ma'am, is it okay now?
Yes, you may continue, Chitra.
Okay, ma'am. Next, about aims and objectives. Main aim is to evaluate the efficacy of individualized homeopathic medicine against placebo in the treatment of menopausal syndrome in blinded and randomized design by using validated outcome measures. Then, to detect the group differences between individualized homeopathic medicine and placebo through these validated outcome scales over the 3 months of treatment. Finally, to shortlist the most frequently indicated remedies. Then, materials and methods. Study site is Outpatient Department of Mahesh Bhattacharya Homeopathic Medical College and Hospital. Study duration was 18 months. Institutional ethical clearance taken from committee. This is the reference number. Then clinical trials registry also we had registered. This is the registration number. This trial protocol and full dissertation was submitted as a postgraduate synopsis and thesis to the West Bengal University of the Health Sciences, Kolkata. Then about inclusion criteria and exclusion criteria. As I told earlier, a patient having menopausal syndrome for at least 3 months, according to ICD-10 diagnosis code, then age 40 to 55 years, then literary patient, then ability to read Bengali or English, and patient want to give consent to participate. These are the main inclusion criteria. Then some patients are excluded due to this reason. These are the exclusion criteria. Like the patient who had artificial menopause and were on HRT, the patient having breast cancer or any reproductive cancers or any psychiatric illness, any uncontrolled systemic hypertension or any diabetes or any life-threatening infections, or already going homeopathic treatment for any chronic purposes, then substance abuse. Then about outcome measures, this is the primary outcome measure, Greene climatic scale. It is a self-reported questionnaire. Here we can see totally 21 physical and psychological and sexual symptoms and somatic symptoms also. Then second outcome measure, this is the menopausal rating scale. It is a health rated quality of life scale. Here also we can see totally 11 symptoms related to psychology and somatic and urogenital and then musculoskeletal areas. Then another one secondary outcome is there, that is UTN quality of life scale. Totally 23 items are there here related to patient's health, emotion, occupation, then sex. Through these outcome measures, we can see the result. Next, about interventions. This is the randomization chart is generated by third party. Then allocation concealment also done identically coded container with the help of identical coded containers, because it is the main thing in the RCTs. Then in experimental arm, individualized homeopathic medicine in centesimal potency given to the patient. Then in control arm, identically looking placebo given to the patient. Then finally, diet management given to the both groups. Then about timelines, patient enrolled in baseline and followed for every month up to 3 months. Then this is a study flow diagram. Patients screened as per eligibility criteria, totally 178 patients. Some patients are excluded due to some reasons, like unable to give consent. Some patient denied to give consent. Some patient took already homeopathic treatment. Then some patient had diabetes medicine, hypertension. Then some patient had artificial menopause, like that. So these patients are excluded. Finally, totally 60 patients are enrolled and randomized, given to for 30% given individualized medicine and another 30 placebo. Then followed every month up to 3 months. Then finally end analysis done. Then statistical analysis. Here we used intention to treat sample method to analyze. For baseline and comparability of the socio-demographic variables, we used unpaired t-test and chi-square test. For intergroup differences, one-way repeated measures of ANOVA used. Then to detect the changes in intergroup differences, two ways repeated measures of ANOVA and unpaired t-test were used. Here we can see in this diagram, we can see the changes in the mean GCS total score over the different point of times in two groups. Then here we can see the changes in MRS total score in two different groups. Similarly, here we can see that UTN quality of life scale scores. Then sulfur, sepia, natramur, pulsatla, lacasis, medorinum are frequently used medicines. Then coming to discussion part, what is the principal findings? In group difference in primary outcome measures, there is no significant result, but there is a significant benefits was elicited in secondary outcome measures in MRS subscale and UTN quality of life subscales. There is no harm or serious adverse events are reported from either group. Then what are the strength of the study? As we all know, this is the gold standard designed to address the efficacy of any therapy and adequately powered trial. Then I strictly followed the principles of homeopathy, then used validated outcome measures. Then what is the weakness of study? As we saw earlier, here the short duration, only 3 months, and small sample size also. And then used questionnaires are only subjective and self-administered measures. So there is a chance for subjective bias. Then due to COVID-19 lockdown situations, some patients didn't come. So we took follow through the telephone. This is the main weakness of the study. Then for what is the further research plan? Further randomized.
Dr. Chitra, sorry to interrupt. 10 minutes are over. Just wanted to inform.
Yes, just a second. What is the further research plan? We can do further randomized control trial with a significant number of samples and increasing the duration of the study at multicentric level. It will be very useful. Then we can see the action of 50 millimole potencies in further. Because here I use only centesimal potencies, we can also see LM potency also. Then conclusion, homeopathic medicine acted significantly better than placebo in the treatment of menopause, but independent replications are warranted. Finally, I want to thank Dr. Subhamay host sir and Dr. Subral Saha sir and Dr. Avaranjika, then Dr. Munmun ma'am, then Akasdeep for their constant support and encouragement. Finally, thank you organizers for giving me opportunity. Thank you.
I will request Dr. Shivang Swaminarayan to give his comments. Thank you, sir.
Thank you, Dr. Matthews. Compliments to Dr. Chitra for being part of the study. The only comment I would like to present here in general is that these are the pilots and wherein the PG scholars as part of their mandatory dissertations. So it becomes more or less making them in sync with what is the research methodology and how to work in the research setup. But when we see the therapeutic areas which are taken up, basically menopausal research, conducting a pilot also for 3 months is not at all a good study plan to reach to any conclusion for that matter. But understanding the background and the basic tenet of the PG scholars to make them in tune with the research methodology, I really compliment all the participants and the presenters for their piece of work, what they have done and presented here. I wish them all the best. And I would also like to press upon one point here, irrespective of the methodology, the RCT or any other method. One thing is for sure that RCT may be gold standard in terms of kind of the evaluationary criterias, but not every disease or every condition need to be put in RCT, because the level of evidences what are required in the different spectrum of healthcare regulatory framework and in public health, it varies. So we need to be more looking at that perspective also. And I would also look at from a different perspective that when any of the study is conceived, generally we see what is the demography of the disease and what is the disease burden. Can we also start looking at the areas that what is the burden, economic burden due to that particular condition, and whether that is relevant or how it is relevant in the geographical space where we are conducting this research. Forget about the national burden, forget about the state burden, but if you are conducting it in a particular area, in a geography, which is in a district place or a taluka place or a urban area or a metropolitan city, at least try to gauge what is the economic burden, social burden of that particular condition of that area. And that would also make your study more relevant to the specific area and the specificity of the same. Thank you very much. And any comments from my colleague, Dr. Shubhamoy?
First, I like to congratulate all the presenters for their tremendous work on double-blind RCT. One key message to the presenter that your work, that is RCT work, will be incorporated in future in systematic review and meta-analysis. That is very, very important in homeopathic evidence generation. Yes. So this is very good information to you people.
Thank you, sir.
And yes, and I like to congratulate our coordinator and moderator, and I'm indebted to organizer who have selected me as a chairperson of this session. Thank you all.
So I move on to the last speaker of this session, Dr. Avaranjika. Please come up with your presentation.
Yes, ma'am, I'm here and sorry for the inconvenience. I think Dr. Nivedita Kundu will share my presentation as I have problem with my laptop. Good afternoon to one and all. And literally, I'm sorry for the inconvenience, and I also don't know why it happened. And myself, Dr. Avaranchika Karupasamy, former postgraduate trainee of National Institute of Homeopathy, and my paper is on individualized homeopathic medicines in treatment of vitiligo, double-blind, randomized, placebo-controlled pilot trial. So I had done the study under the guidance of Dr. Swapanpal sir and our team, and I'm very much indebted for my team for this paper. Next. So why we had choose this topic? And first, let us see the prevalence all over the world. It was around 0.522% prevalence. And in India, the burden was little bit high, and it was 0.25 to 4%. And even though we can see some physical illness, but this vitiligo have a major impact in psychosocial aspect also. So we thought about doing the literature review. That time we found that no treatment modality is found to be curative. So when we had done homeopathic literature review, we found 5 observational trials showing the promising effect of homeopathy on vitiligo. So we thought about doing a randomized control trial, but we found the most forerunner, that is pilot trial, is much needed to do a definitive trial. So we thought about this topic. So the aim and objective is the current trial was conducted as an external pilot, and we had explored only the feasibility of an adequately powered future trial of individualized homeopathy medicine in vitiligo, and we had identified preliminary indications of the treatment effects. Next. And the study setting, we had done the study in the outpatient department of National Institute of Homeopathy, and we had got the institutional ethical clearance from our institute, and we had registered our trial in Clinical Trial Registry of India, and this is my postgraduate thesis. Next. So inclusion criteria, the patient suffering from vitiligo since at least 3 months, and the patient had been coded under ICD as L80. We had not revealed the diagnosis to the patient. So the age is between 18 and 65 years, and the patient of either sex, and the patient should be able to read English and Bengali, and we had provided the written informed consent in both the languages for better convenience, and the patient who have not taken any treatment for vitiligo for 2 weeks, and this is the inclusion criteria. Then exclusion criteria, the patient who was very sick for the consultation, and if the patient is suffering from any other skin conditions, morbid skin condition, or if the patient is having some unstable illness or uncontrolled systemic illnesses, we had excluded the patient, even if the patient had reported any immune compromised state, or the patient had undergone any homeopathic treatment for the chronic disease at least 6 months. Then. And the intervention, here we used the most novel thing which I found very good is that the experimental arm had been given only individualized homeopathy medicines from 50 millisieverts. That was the new thing in our research. And the control group carried the identical looking placebos, and the duration of treatment was 6 months. So let's start with the primary outcome measure. Primary outcome measure is completely objective, and it was done by a dermatologist who was blinded already, and it was vitiligo area scoring index, where there will be multiplication of the hand units with the residual depigmentation. We have a specific pattern for it because it is completely based on rule of 9, Wallace rule of 9, which we used to calculate for the burns. And the second thing is secondary outcome measures, that is vitiligo quality of life and dermatological life quality index, which will be carrying out all the psychosocial domains which will be affecting the patient in a day-to-day activity. And the timelines, we had recorded the scoring from baseline and on 3rd month and the 6th month, after 6th month. Then. And this is a study flow diagram. We had screened and enrolled nearly 86 patients, and because of issues like illiteracy, denied consent, and universalis, vitiligo universalis, and the patient already undergoing homeopathic treatment, 26 had been excluded, and at last we got 27 patients in each group entering into the final analysis. But here, as we had used intention to treat approach, we had took total 60 patients in the end result. Next. Okay. Thus comes our result. As I had already mentioned, this is our pilot trial. We are focusing only on the feasibility issues, and we found the recruitment rate and retention rate very satisfactory, and there were no obstacles related to randomization and double blinding, outcome assessments, follow-ups, and ethical parameters. And this is our standard error bar diagram showing the changes in vitiligo area scoring index and vitiligo quality of life index. We can see the difference. Then these are the error bar diagrams showing the difference between the baseline and 6 months of patient assessed severity and DLQI, and that we can see the differences between baseline and 6 months. Then. And out of the medicines, frequently indicated medicines, the topmost one is sepia officinalis, which we are very clear from our literature. Also, we have a lot of indications for sepia from boric repertory, like lot of the most used repertories, basic repertories. And then comes arsenicum album, then comes calcarea carb and natriumur, which had been given for almost 5 patients each. Then. And now comes our principal finding, which is more and more important. We found a mean reduction in the outcome measures, which were higher in individualized homeopathy medicines than placebo. As I had already mentioned, this is our pilot trial. We cannot take all the results directly into next trial or next recommendation. So we have to plan for a definitive trial, which will be good or which will be replicable in the latter aspects. Then the strength of this trial, that is the golden standard of research. We had followed randomization, double blinding, placebo control, and we have the expertise of dermatologists in diagnosis and assessment of outcome. And we followed intention to treat analysis. So every patient had been given, and like we had took every patient to the end result following the LOCF method. And we had used pre-validated outcome measures, and we had adhered to the classical homeopathic principles, and we had followed a consensus of 3 to 4 people before prescribing the patient. Like we team members used to have that consensus discussion. Then we had used 50 millisimal potencies, and we found similarity of 2 groups at the baseline. And the main weakness, the trial is underpowered. As we know, like powered trials should be given replication. So we are considering it as a pilot trial, but as it is underpowered, we should not interpret the result very easily. It should be cautious. And as I mentioned, the duration is 6 months. It is very short to assess a chronic condition like vitiligo. As an autoimmune disease, we have to give a longer duration of 1 year to 2 years so that we can get some idea, and the nature of the disease is already relapsing and remitting. So we have to think about it also. And the formal validation of VTQOL, that is vitiligo quality of life, a questionnaire is not yet published. So that can be considered as a weakness. Then the conclusion, this pilot trial ensured the feasibility of a definitive efficacy trial by addressing the feasibility issues and revealing some promising effects of individualized homeopathic medicines against placebo in treatment of vitiligo. And the publication status, the paper got accepted by the peer-reviewed Journal of Alternative and Complementary Medicine. Now the paper is in press and it is about to be published. Thank you so much, and thank you so much for all the patients who had participated in the study, and my teachers and all the researchers in homeopathy for making me to do this study. And thank you very much for my team and my organizers from LMHI for giving me this opportunity to present. And thank you, Dr. Nivedita Kundu.
Thank you, Dr. Avaranjika. I will now request Dr. Shivang to give his comments regarding this presentation and also the summary regarding the whole session.
Thank you, Dr. Matthews. Compliments to Dr. Avaranjika for study on an important skin issue, which is more or less a socio-cultural issue rather than a disease per se. And in Indian context, it has got a much relevance. And as you have rightly admitted, that these needs cannot be the further larger study, and maybe eventually we can also see various studies and a cohort of the same. But at the same time, every study, small or a big, whether a positive result or a negative result, has got an immense value in the scientific world for the scientist and for further research. Because whatever lacuna or whatever shortcomings of one study can be overcome by the next planned study by yourself or anybody else who may be able to take it further or would like to take it further. In fact, I'm very happy that once upon a time it was talked that RCT is not possible for homeopathic interventions. And today I see that the whole session, and I would say that not only one session, but various parallel sessions wherein the scholars and scientists and academicians are working on various RCTs, making it robust, making it kind of be more acceptable from the homeopathic perspective, as well as on the global level by the other scientists. That's a very promising time that I am seeing for homeopathy at large. And we have already demonstrated the nanomolecule or nanoparticle in our dilutions, so negating the Avogadro theory. Similarly, with the scientific temper and the scientific rigor, homeopathic world will demonstrate in time to come that it is a system of medicine which cannot be neglected or which cannot be negated. This is a time for integrated research. So today we could see only the RCTs with placebo-controlled double blinds, but there is an immense scope of add-on therapy also with homeopathy and various other things. And eventually we'll be also seeing those studies and outcomes by our various colleagues during the colloquium and in different fora. I would like to thank the organizing committee to give me a chance to chair this session and listen to the wonderful studies that you all have conducted, and the immense the enthusiasm that goes into it, that I can see that is being reflected while you are showing, while you are presenting, the glow on your face. That gives me and all of us a good, I would say that confidence that the future is very bright for homeopathy and homeopathic scientific rigor in time to come. Thank you once again to LMHI. Thank you, Dr. Matthew, for coordinating and moderating the session, and also the coordinators for the session for supporting. Thank you very much, and wish all the best to each one of you.
I thank both the chairpersons, Dr. Shivang Swaminarayan and Dr. Shubhamay Ghosh, for sparing their valuable time especially for this very valuable session. Thank you, sirs. Thank you.
So we now conclude our afternoon session. There were some technical glitches, which is a limitation of a virtual conference. Sorry for the inconvenience caused to the chair as well as the panelist.
That can be compensated with a group photo on virtual.
Sure, sir. And, I request everybody to switch on their video for a photograph session.
Okay, ma'am.
Thank you. Thank you, everyone.
Thank you, Anu.
Thank you so
Thank you.
much
Thank you, sir.
for, it was
Thank
a
you all.
wonderful evening.
Thank you. Thank you.
Wish you all have a wonderful evening.